So, welcome to the Trust Me, Talk to Me, and let me start the day's proceeding first with Kavita. Kavita, so it's very bold of you to have come forward to share your life experience about a subject which some people find a taboo. So, tell me what made you do so?
Thank you, Doctor. First, you've already said it was Sushant Singh Rajput's death. And I personally hadn't found any forum to speak on and vent out myself. And the third is I'm a very impulsive person. So I asked my daughter, like I'm feeling like there should be somewhere on Facebook where I can vent it out because they were all people from abroad and there was no Indian per se group where I could connect with. So I just started it. It was just on.
So, for how long have you had this difficulty or challenge where you have felt low or depressed?
Well, I have been fighting depression since more than a decade now. And
Okay.
yeah, I don't know how it came about,
How
but
did
I
it
had,
start?
well, my neurologist, who I think you would be knowing, Dr. Rajshekar Reddy,
Right.
I had a brain stroke.
Hmm.
So he was sort of expecting this to happen to me.
Okay.
So when I went crying to him,
Yeah.
literally,
Yeah.
he said, okay, you need to see a psychiatrist. So that's how I saw the first psychiatrist that I did.
So, how
And
long back was that?
that was 12 years back.
12 years ago. Okay. And so, what did you feel, or what do you feel when you are depressed? Is it just you feel sadness, or is it something different from that?
It's a all pervasive gloom.
Okay.
Nothing is okay. And nothing which I can put my finger on makes me cry, but everything makes me cry and sob. And as you know, sometimes it just goes into the suicidal mode for no rhyme or reason. There is, I have been trying to pick up a trigger like, is that what triggers me? Is that what triggers me? Sad songs don't trigger me. In fact, sad songs make me feel happy, which is kind of a, I don't know. It's very, it's very sad to say that, but that's what it is.
It's not sad, it's actually a fact. It is a known fact that sad songs actually help relieve depression, but we'll have our expert talk about this later on.
Yeah.
And okay, so you said that there's no reason for you to feel sad, there's no reason for you to think, be suicidal.
Well, not now. But yes, there was a past in my life when I was under abuse. So at that time, if I stuck on and I fought back and I raised my children, now I have adult children.
Right.
So why should I be feeling that way? They are 28 and almost 22. So I should be feeling happy about that. And I see them succeed and I am happy.
So you're fully aware that yes, it is something, it's not, it is circumstances, but it is the inner feeling or the state of depression which makes you feel that like that.
Yes, and I read a lot, so I know that could be a chemical imbalance. I feel there's some wiring wrong in my brain suddenly because that's what Dr. Reddy told me at that time. The stroke has touched some kind of a zone in your brain.
Hmm.
So possibly that, I am not too sure. But antidepressants help me, contrary to the view that I am on drugs, which I want Dr. Manpreet to address today. Antidepressants are something that help me out. They are not unprescribed. They go with prescription. They come with prescription, and I
So,
don't know why
so
people.
what made you go to a psychiatrist?
My neuro doctor, he said,
Okay, he
you go
advised.
there,
Right.
and but those medicines didn't suit me, and I found him he wasn't listening to me.
Right.
So after changing three psychiatrists, I finally went to a lady. I
Hmm.
don't know whether the gender was different or whether she heard me out. That helped me,
Right.
but it has helped me. Nowadays, I feel that the medicines I've sort of outgrown them, or their dosage is not. I don't know what's happening, but she's laid back in the bed with a back fracture. So
But so finally, the medicines did help, and of course, you took some time to choose the right psychiatrist with whom you could click.
yes,
Did you try psychotherapy also?
no, that has been quite. Actually, that has been the zone where I haven't been very gung ho.
Okay.
I find the same sort of solutions being told to me: meditation, yoga,
Mm-hmm.
physical exercise,
Right.
breathe in, breathe
Right.
out. Uh,
Right.
all that is same. If I
Right.
come across somebody who's something out of the box, then of course I would love to try that.
But these are the lifestyle adjustment changes that you're talking about. But have you undergone proper counseling?
No,
No.
I
Okay.
have, yes, but it was a disaster. It
Okay. Why was it as a disaster?
I was blamed by the counselor, so obviously it was a
Okay.
disaster.
Okay. So, well, one point is very clear that at both the times, where you could relate to the person, you did well. So you
I,
could relate to the psychiatrist, you did well. And where you could not relate to the psychologist or the psychiatrist, the treatment did not have any positive effect
no,
on you.
no.
So that's a very good thing. We have seen your posts in the recent few days, and you even referred to the death and the dying thing. And so, what made you write those things? And we'll talk further from there. So what made you write those things, though?
uh, the thing is that I know I know my family is watching this, but still there are times when the impulse out goes out of hand.
Right.
You feel that there's nothing to look forward to, which is quite actually wrong. I have my daughter's marriage to look forward to. I
Mm-hmm.
have to see my son successful, more successful. I
Mm-hmm.
have a whole lot of things in life to look forward to.
Mm-hmm.
But there's one issue which bothers me: financial dependence.
Mm-hmm.
So that has gone out of my hand.
Right.
So I feel okay, life has ended for me. At 52,
Mm-hmm.
I feel okay. I'm 82, like my father, and
Right.
I'm going to. I should be dead. Before I see anybody going,
Okay.
that's another thing. I don't want my parents to go. So okay, I'll go first. I don't want to see anybody going.
Mm-hmm. So good. And so, what message do you have for people who feeling low or who are facing depression, or who think they have depression or who know they have depression, and what should they do? What is your message for them?
Well, for them, I would obviously say don't hesitate to speak about it.
Right.
But the message is more to the listeners.
Hmm.
Please listen without judgment. Please don't brush it away as saying, come on, it's just a mood. You're fine. Or don't talk stupid. Or antidepressants are drugs.
Okay.
Sorry. I'm not a drug addict.
Good, good, Kavita. So I'll keep coming back to you maybe during the show when
Sure.
I'm talking to Manpreet also. And that's amazing. And that's very brave of you to have come out so openly and talk about your difficulties. And yes, a very good point that you brought up is that the listeners, please listen without judgment. And also, I would like to tell all the audience here right now that this today's conversation is a very heart to heart conversation. We're talking about things which are very close to heart, which are very, very confidential to us. Please respect the confidentiality of people who are here today, who are talking, who are sharing things. No, do not talk about this outside. Do not be judgmental. And if at all, provide a support, uh, give a supporting hand. Today they are in bad shape. Tomorrow they may be in good shape, and you may be in bad shape, and they may be able to reciprocate by their support towards you. It's all give and take. So let us have be a group where we actually help each other, support each other. So bringing in Dr. Manpreet, welcome to the show, and thank you very much for being here, for agreeing to be here and to talk to us. And I know that you have a limitation that you are working in US, you have a US license, you're not supposed to prescribe or treat any patient overseas, but you can always guide us, and we need your guidance, we need your expertise, we need your knowledge and information. Uh, so welcome to today's chat show. So I'll start with a question to you. That first of all, what made you interested in this group?
What made me interested in this group?
In this group, yes.
I see patients who are going through depression on a daily basis, but then there is somebody that in this case, Sushant Singh Rajput. I am a big fan of his. So when something like this happens, it just brings so many things that we don't talk about it. There is some detachment. We don't see it coming to our loved one. When something like this happens, and this, trust
I
me,
think you need to speak a little louder because you're not as well heard by audience.
Can you hear me now? And you know, this is my baseline talking. I always talk softer. So I'll try to speak as loud as possible so as I'm audible.
So you scream at me now, okay? Just consider that I'm annoying you and you have to scream at me, so talk as though you're screaming at me now.
Okay. So the motivation for me to be a part of this group is I see patients like this on a daily basis. I know some of the stigmas that are associated with it that makes the depression go on for a long time. And I know depression is a condition which is treatable. There are many patients that I have seen in the worst phases of their life. I have followed up with them and they have gotten better. Not just they have gotten better, their family life overall, their functionality in society has gotten better. So that was a motivation for me to be part of this group. So whatever I know, whatever education I have in this field, I can share it with people who might benefit from it. That's why I'm here.
So I'll start with a very, very basic question first, that what is depression? We all feel sad, we all feel low. So is it the same sadness and low feeling, or is it different? So what exactly is depression? Let us know that first.
So again, I reflect back on what Kavita said. You know, it's very hard for a person who has not gone through clinical depression to understand what we are talking about, what that person is going through. So sadness is a normal human emotion. We all go through that phases. We all have setbacks in our life. We have gone through breakups or failures or some instability at job loss, some relationship problems. We all know what that feeling is when we are feeling down and low, not up for it, and we are feeling sad. So depression is not that sadness that comes and goes. Depression is something where we are talking about a mood issue which is going on for so many days, most of the time, all day. And it's not just the mood symptoms we are talking about. We are also talking about some other, say, changes in our body that goes along with it. So when we talk about clinical depression, takeaway message from me is it's not sadness that just comes and goes. So clinical depression is, there are two things which are very important, and one has to have either of these to make a diagnosis of clinical depression. The first thing is a mood change. So we are talking about a low mood, sad mood, not feeling up for anything. But many times patients, when you ask them, what's your mood like? They may say, I don't know. Or they may say, I don't feel anything. I feel numb. So this is a change from what they usually feel like. This is not their baseline mood. So sadness of mood change. And the second important thing is loss of interest in things which somebody used to enjoy before. It could be anything, simple things like, say, singing, or say somebody being into fitness, somebody into cooking, spending time with their kids. They don't have interest in that. You know, even it's as basic as me wanting to talk to my friend. I start to get withdrawn. I don't have any interest in engaging with anyone. So sad mood, loss of interest, one of these two things have to be there, at least for 2 weeks, almost every day, most of the time. So it's not like it's coming in waves, it's there, it's hitting you for say 2-3 hours, and then you do things, you're out of it, and rest of the day you're fine. So it's something that's lingering on. You know, this is not your routine self. This is not your, you know, this is not the self that you would want you to be in. You're trying really hard, but you still are not able to come out of it. So these are the two important things which are very important for a diagnosis of clinical depression. But other than that, like I said, there are changes which are happening at the body level. So for example, sleep disturbance. So a person may have either difficulty falling asleep or difficulty staying asleep. Many times we see what they call early morning awakenings. So say if my waking time is 7 o'clock, I'll wake up for no reason at 3 o'clock, and then I'm not able to go back to sleep. I'm tossing, turning in my bed, I'm not able to sleep. So sleep can be decreased, it may also be increased. I have seen patients who sleep for 18, 19 hours a day. All they wake up is for, you know, just somebody's waking them up to eat, or they have to go use the bathroom. So it could be decrease in sleep, it could be increase in sleep. The second important thing is change in your appetite. And that also comes from the fact that you're not interested in anything. So you may go on for a couple of days where you have not eaten a bite of anything and you're just going on. And contrast to it, there may be patients who eat too much. Sometimes it may be thought of just a way to compensate, feel good things. Some say junk food or food can become a source of comfort. So those patients may have increase in their appetite. We talked about sleep, appetite. There is a decrease in the energy level. People are feeling so tired that they have absolutely no desire to even get out of their bed. So there's basic things. It's not just energy to carry on your job or cooking, cleaning. Very basic things can get affected. The person may not be up to just getting started with the day. Seeing yourself in the mirror, washing your face, brushing your teeth, you're taking a shower. None of that is happening. You're so much drained that you have just no desire to get out of bed. And it's not just the person who is going through this low energy, it's also something that will be seen by the family members. So people, they do notice that this person is an extrovert person, usually engages with kids, engages with husband, spouse, but now is withdrawn, is just sulking and staying in the bed all day. And it's not just the way they are doing day-to-day things, it's also the thinking is slowed. So not just you see a person who is kind of stooped or slumped, walking slow, talking slow, their responses are very slow. You ask them something and then you're just literally waiting in the air. When is the response going to come back? So there is this body tiredness, there is also this mental tiredness, which we call lassitude. So we talked about sleep, appetite, energy, that is being observable by others else also. In contrast, there may be people who are very agitated or very restless, and they are just not comfortable in their own skin. Then other important thing is about the concentration. Even in talks, I might be talking to a friend, but my mind is not there. So they may ask me multiple times, are you even there? Are you listening? Small things. I have had patients who have cooked same thing forever, and now when they go to make tea, they don't know what to do first. So their mind is not there. Then now if we are working, somebody may push through it and may still try to show up at work. Or students, they may still try to keep up with their school work, but they are not able to accomplish anything because their concentration is so impaired. So of all these things that I mentioned, the most serious of it is there are frequent thoughts of death and dying. When you're living in this misery for such a long time and you just can't shrug it off, it becomes very difficult to carry on your life. There are a lot of cognitive, what we call cognitive ruminations, a lot of guilt feelings happening that why this is happening to me. Why is it that I cannot be the parent I want to be? Why can't I be a spouse that I want to be? Why am I putting my family through it? And then it starts bringing all those feelings where I feel worthless. I feel like there is that pessimism that dawns on me, that this is a permanent thing. There is no way out. This is a kind of a lost cause. So I would rather be dead. My family would rather be happy without me. So all those thoughts, they keep on playing again and again. Even though my value system may be that I'm a very resilient, I have suffered in the life and I have struggled through it, I have come out successfully. That's a state that I'm at a verge of feeling so hopeless that I start believing that if I'm not there, things will be better off for everyone. So now when we are talking about those thoughts, sometimes it's passive death wishes, that I just wish I disappear. And I just wish something happens to me. Corona happens to me. So many people are dying in the world, why not me? So sometimes it's passive death wishes, but sometimes it gets to the point that, okay, enough is enough, I quit. And people are actually thinking and putting some plan in place. They're thinking about different means how they can act and they can end their life. So when we are talking about clinical depression, it's not just sadness that we can brush it off. It's a cluster of all these symptoms we are talking about, which is going for at least 2 weeks, every day, almost every minute of our day. And so that's clinical depression.
So is there a preclinical depression or a milder form of depression where you don't see these symptoms in that much of severity? Or can we classify depression into mild, moderate, severe somehow?
Yeah, again, that classification is very arbitrary. where we put that line, what is mild, moderate, severe. But just the basics or just the crux of it, how much of impairment it is causing in my personal life. And it also depends on how much it's absorbing my day-to-day functioning. So again, I may start my day with that, but then I use my tools, I use my coping skills, I use distractions, I'm out of it. So again, that can qualify it as mild. But then say it's like, say if somebody has a fall, the arm is broken. Now you can use conservative measures, you can take paracetamol, you can take ibuprofen, you can use cold compresses, whatnot, and the pain heals. I'm still functional, I can still use my hand, not a big problem. So that's kind of mild depression where I can still take it on, I can still be functional, I can keep going. But if the same thing keeps continuing, say now you start having swelling, now your arm is, you can't even move the arm, there is no motion, you can't do normal things. And then you start feeling like, is there a fracture? Do I need to see a doctor? Do I need something else is going on internally? So there we are going from the, there we are kind of getting to the extreme points, which is moderate and severe.
So can a person recognize depression in its early stage with milder symptoms? And can things be done to prevent from becoming more severe?
Yes. So many times the person by themselves, they are not aware of it. They may feel, and this is one of the common misconceptions that we have. We sometimes feel that, say, if the stressful situation is going on, our response is very normal. And it's a normal human emotion. So where that boundary is being crossed, where we are getting to the point that we actually need treatment, part of it is subjective, that I am aware this is not me. I am not happy with this. I don't want to be in this state. I want some help. So because I'm trying all I can, I'm not getting better. So part of it is our own self-realization that this is not just normal sadness, this is more than that. So the person can be aware, like I talked about, all the different symptoms once they're educated, once they know. Once they have gone through experience multiple times in their life, and they know from their previous experience that last time I had it, I didn't get help, it went way too far. So there they can be more aware to recognize the early changes, and they can do some interventions to make it not progress further. Sometimes it's not that subjective. The person may be in a denial, but it's the family members around who are noticing that something is not right. And they can raise the alarm. They can bring it either to the patient's attention, or they can gear the patient in a way that you need to ask for help, you need to seek help, either from friends, family, or from professionals. So, yeah.
So, what are the key signs, where you say, okay, fine, this is, to recognize depression, and where a person needs help, person needs intervention? A person, what signs the person can notice himself or others can notice? So what are the key things where you say, okay, fine, that's where help is required?
The key thing is that you are noticing you are in distress all the time. You're not being yourself. You want to come out of the state, but you're not able to do so. So like I said, all these symptoms, sad mood, again, sometimes that is not even recognized. The person themselves may not put a kind of a name to it, put a word to it that I'm feeling sad or low. They may feel that I'm just not feeling anything. I'm absolutely numb and detached to whatever is going on around me. So
it's loss of interest. It's loss of interest.
Loss of interest. That's why one of these two things, even to make a clinical diagnosis, we are okay with either of these, in addition to other changes in your sleep, appetite, energy level, concentration, suicidal thoughts, vulnerability to others.
So what causes depression? Is it, as Kavita said, there's some changes in the wiring, some chemicals in the brain? Is it genetics which is at work? Is it environment which is at work? Is it person's circumstances which are at work, and is it, say, some trauma that person experiences in childhood or trauma faces later in life? Like there's a pandemic now, so what causes it and what plays a role to contribute to it?
I think you kind of covered, the answer is all of these. So what causes depression? Even before we start our life, even when we are in our mother's womb, there may be changes happening that is shaping our neurons, our neural structure. Our brain is being subjected to, say, if mom is even going through illnesses or some drugs or some infections, that can start even before we are born. It can make us predisposed to depression at some point in our life. Genes play an important role. So if, say, my parents or my brother, my sister, my first degree relatives have had clinical depression in the past, that definitely increases my risk to have depression any point in my life. So genes play an important role to kind of develop the biology of me, that defines my brain structure, my neurons, the neurotransmitters, the receptor levels, the hormonal pathways in my brain or otherwise in my body, thyroid functioning, adrenal functioning. So the biology plays an important role to either predispose me or make me somehow more resilient. But it's not just the biology. Not everybody who may have a very strong family history of, say, depression, not everybody who has it, even though their risk is 4 to 6 times more than somebody who does not have a family history, they may be facing the situations or crises in their life without going through clinical depression. So again, genetics by itself does not, it increases the risk, but it does not it's not the only answer. So the accepted fact is that it's a combination of the genes, it's in addition to the social factors, psychological stresses. So there are a lot of psychosocial factors, and we can't tease them apart, like how much is coming from the genes, how much is coming from the psychosocial factors. They all interplay to the point whether it makes us resilient or it makes us end up having clinical depression. And like you mentioned, there are some very known stressors which definitely increase the risk of depression. For example, trauma, any times in our life, but especially childhood trauma, childhood neglect, childhood upbringing in families which did not care or were neglectful in their interaction with the kid. So childhood, any trauma, physical abuse, sexual abuse, neglect, that will increase the risk. And that kind of makes an imprint that kind of, it shapes our thinking in a certain way. So later in life, in our 40s, 50s, we may do well rest of our life, but some psychosocial stressor happens and it definitely predisposes us to. The trauma is one thing. There can be other acute changes, life changes, transitions that are happening. Say, for example, loss of a job, loss of a loved one, death in the family. Sometimes, say, retirement. Sometimes people have been used to a certain way of living, but now it's altogether life-changing for them. They don't know how to cope with it. So sometimes it's the medical conditions, like Kavita mentioned, a stroke happened 12 years ago. Before that, she was fine. And with a stroke, there are, stroke or any other, some chronic illnesses going on, which is destabilized at some point. And we feel lost. Sometimes because of the medical condition, we may get started on medications for that. Say simple things like, say, blood pressure or diabetes, and our sugar is not regulated. So there are medical factors going on that can also predispose somebody to depression. So there is no one answer. It's a combination of all these factors that can cause clinical depression.
Good. So then how do you go about managing, treating? Let us start with self-help. What is it the person can do himself or herself to, maybe prevent depression or to treat it, manage it in early cases? What is it that the friends and family can do? When is the role of, say, an expert is required, and who are the experts? Psychiatrists, psychologists. Please tell us all about this.
So the early signs of depression. Something is popping on my computer. So when we are seeing the early changes, or we are in that phase where we are feeling that we are coming down, we are spiraling down, we can catch it up early on, either by our own awareness or by family members bringing it to our attention. So there are some things we can do in our lifestyle, which are more what we call health promotion, health promoting things. So even if somebody does not have depression, they can still do things on a daily basis that will reduce their chances of slipping down. So for example, very basics, taking care of my nutrition. So I may not be up for it, I may be lazy about it, but if I'm maintaining my nutrition, not engaging too much into, say, junk food, or having a more balanced diet, That is one thing. The second is the sleep. The sleep, I can't even overemphasize. That's one of the changes, a good quality sleep, restful sleep, which is not distracted by electronics or any other engagements. As long as I am giving myself 7 to 8 hours of restful sleep, my mind needs it, my body needs it, that reduces my risk to start slipping down. Exercise on a regular basis. There is so much research that has been put into it that just regular exercise on a daily basis, that has got protective benefits. In fact, there was one study which talked about, it compared in contrast to SSRIs, which are the antidepressants. So they compared antidepressants versus exercise, a structured exercise for about 10 weeks. And they found out that if we are doing about 3 to 5 sessions of 45 minutes each every week of any aerobic exercise, be it walking, running, swimming, bicycling, just playing around with our kids, something that is raising our heart rate. So if we are doing it about 3 to 5 times a week for good 45 minutes, that has protective benefits. They did that study for about 10 weeks. And they found that those patients, even in the mild form of depression, they were doing equally good than somebody who was on SSRIs. So that's huge. How much is the role of exercise, physical exercise, being outdoors, being exposed to sun, how that all plays in our regulating our mood. And again, some lifestyle changes, we talked about sleep, appetite, some high risk behaviors which need to be avoided. Say, for example, sometimes people, they try to cope up with their stress by, say, alcohol or some over-the-counter drugs or other risky behaviors. So avoiding those high risk behaviors, that's also health promotion. So that can not just kind of curb it before it goes too far, but like I said, it can also treat when we are in that stage of mild depression. In addition to that, developing some kind of hobbies or some things that we enjoy doing, spending some time on a regular basis that we actually enjoy. We feel productive. We feel that we are being us. We are using ourselves in a more productive way. So taking time for ourselves in self-care, self-compassion. So these are more, it can prevent, but it can also treat signs of mild depression. So now, like I said, we are doing all this. I catch it. My husband tells me I'm going through this, so I need to take care of myself. And I can catch it. That's good and fine. But say, I can't motivate myself to even do things, even though back of my mind, I know I have to sleep, I have to eat right, I have to go for exercise. As my depression is proceeding, as my depression is getting worse, I just don't feel up for it. Loss of interest. So I may be aware, but I may be not able to put it in place. And this is not that I'm being lazy or I'm being flawed or I'm being a difficult family member. It's not that. There are some things which are beyond me. And when it's progressing to that extent, either I recognize that I need to see a psychiatrist or a therapist, or my family, they encourage me or they care me, they remind me how important I am and what I'm losing in life. So that can make somebody convinced to either go see a therapist or a psychiatrist. Now, sometimes people would not go, they may have these signs, but they may not even realize that it has anything to do with their mind. They may not see it as a mental process going on. Many times we see patients who will first go to their general physicians and they're talking about more physical symptoms, like their asthma is out of control, or their blood sugar is all over the place, joint pains, or just that lassitude, that tired feeling. So it may not even go to a psychiatrist or a therapist or a mental health professional at first place. Sometimes it may be noticed by the primary care provider, by some other, like in Kavita's case, it was the neurologist who brought up, that you're crying too much, you're sad, you're gloomy, maybe it's time to see a psychiatrist. So now, again, depending on how much impairment we are seeing, depending on how much it's kind of consuming our life, we make a decision whether it's good to start with just the therapy process where we are having talk sessions with somebody, or it's good to start with some medications. And the usual consensus is that combination of treatment along with all the lifestyle changes we are doing, that has the best benefit. So combination of medications that are commonly used in addition to some form of psychotherapy. that can be beneficial. But then it also depends on patient preference. And it also depends on psychoeducation as to how prepared somebody is to give it a chance. Like she mentioned a great point. Many times, even the family members, they take it as, I mean, you're okay if you're having pain or you have a fracture, you can take pain medications, but talk about depression, being on antidepressants. There is so much stigma about it that patient may label you as a drug addict. So that can create that resistance in your mind that I don't want to be on those medications. So the patient's comfort level and the extent, psychoeducation about it, like what are the benefits about these medications? What are the risks that are involved? And kind of just being a team member in that can help us decide what's the next foot forward. Is it a combination treatment or is it just the therapy? Now, sometimes, say moderate depression, where we are not talking about extreme impairment, but it's still not something that we can control on our own hand. Starting with a therapy is a good idea. And there are different forms of therapy they have an evidence that it works in depression. Human connection is so important. We are not working with robots. So if you can't click with it, there is no way you can talk about your more personal feelings, what you're going through, how you're seeing the world, how you're seeing your life as. So having that rapport is so important. And then based on, where you are, it's kind of trying to meet you where you are instead of trying to, you can't sell that either cognitive therapy is good or interpersonal therapy is good or say psychoanalytic therapy is good. The role of the therapist is to find you where you are and see what would work best for you, giving you kind of education as to what the process is like, what is your comfort level with it, and are you willing to commit your time, your energy, your faith in that process. Okay.
How much time does it take typically for medicines to act or to show some positive effect?
So the SSRIs, they are the first line of medications, and we are talking about common medications like fluoxetine or sertraline, Zoloft. Some benefit starts, if it's a good fit for you, some benefit will be noticeable in 1 to 2 weeks. But for the complete benefit to be prominent, it takes about 4 to 6 weeks. And that's part of the psychoeducation that do not expect sudden drastic changes. Many times patients will give up in the course of, say, 5, 6 days, 7 days, nothing is changing, nothing is getting better. And that's kind of premature termination of the medications. So that's very important point you brought up. It starts in about 1 to 2 weeks, may take anywhere between 4 to 6 weeks for us to see the maximum benefit from it.
And how much time does it take for the psychotherapist or psychotherapy to start showing some benefits?
That's a very, it's a very patient kind of, it depends. Everybody, it depends on, first of all, it depends on how much you are committed to it, what faith you have in it, what you want to get out of it. If you have some resistances to begin with, if you're already starting with a hopeless state of mind that nothing has worked for me, it's the same old broken record, all the therapists play. If you're going with that attitude, then probably it would be a little bit more time consuming. So again, it's so important to have that therapeutic alliance, to have that rapport with your therapist, that somebody who is not just cheerleading you, not just saying all the positives, but also bringing your attention to where you need to make a change. Like Kavita brought up this point that those therapists were constantly, they were criticizing you. You can't work with somebody who is either too overtly critical or too overly too validating, praising all the time. There has to be a good balance to see the right benefit coming out of those therapy sessions. When we're talking about therapy, we have cognitive behavioral therapy, interpersonal therapy, the behavioral therapy, which is more short-term. We have a timeline. It's not something that goes on forever. So on an average, the sessions may last anywhere between 8 to 12 weeks. Sometimes it may be extended plus minus 4 weeks based on your response. So these are more timeline. They are more problem focused, living in here and now, dealing with the acute problem where it is. In contrast, there may be some people who may want to kind of explore what's the root of it? Where is it coming from? Why am I thinking like this? Again, sometimes depression is not, we discussed about it earlier, depression is not just some stressor going on in my life and that's how I respond. It's also something that can happen when everything is going on right in my life. So these are the patients, yes, they want benefit, they want to get better, they want to live a productive life, but they also want to figure out what's the root of it, where it is coming from. So those are the patients who are more appropriate for, say, psychodynamic therapy or psychoanalytic therapy, which is something that may go on for life sometimes. I've had patients for all my residency years, they literally grew in front of me. So 4 to 6 years of their life, they were in that process, and slow and steady change happened. So now good thing about therapy sessions is that it's kind of changing the way you think. You know, at a very basic level, it's changing your thoughts, giving you not just the coping skills, but also letting you know more about yourself. So the benefits of therapy, they go much beyond what we can achieve from antidepressants. So that's the plus thing. There is one thing I want to share. This is something that I talked to my patients who are having some hesitation. You know, they may have moderate depression, severe depression, but they may not be up for treatment. Treatment in the way the medications. There is one example that I give. Usually it works very good with teenagers. So I give this example, like if say overcoming your depression, getting better is like say learning to ride a bicycle, right? Medications is something that is making sure that the tires are all full with, tires are filled with air. You have the right air in your tires. Your bike is it's oiled, it's in a proper working condition. But then somebody may give you a bike and you still may not know what to do with it. So going to therapy is more like learning how to pedal, learning how to maintain that balance, learning how to manage your speed when you're going uphill or downhill. So going to therapy is more akin to learning those skills, participating in therapy. So sometimes it works with teenagers to kind of emphasize on the importance of both medications and therapy being the part of the process.
Okay, so I'll ask one last question before we take the audience question. And that is that when do we raise the alarm? That is, when as a person himself feels suicidal or somebody else notices it. So what is the time to raise the alarm, and to who to raise the alarm?
So again, suicide is the extreme that we are talking about. So a precious life, which may have had a lot of potential being lost. So that's a psychiatric emergency. So suicidal thoughts, somebody is talking about it, somebody is being courageous enough to bring it to our attention. That is not to be taken lightly. That is number one. It should ring all the bells from everywhere. So as all the resources, all the support factors, they can kind of be guided in a way to protect that life. Now, when you ask about when to raise the alarm, to me, depression is not just it's kind of consuming or impairing you, it's also not making you work to the best of your potential. When you're feeling distress, every life deserves to be happy and lead a meaningful, productive existence. So if you feel you want to do that, you're not able to do it, for me, it's a need to raise the alarm so that what steps need to be done can be taken in a rightly manner so that, the spiraling down can be prevented, but the last of all, the loss of life through suicide can be avoided. So now suicides are common. 2/3 of people who are going through clinical depression, they have suicidal thoughts. So that's a huge number. 2 out of 3 people have suicidal thoughts. Now, how many act on that? That's a little bit, it's a very significant number. 10% at least end up committing suicide. And these are the people we are talking about who just have clinical depression, not any other confounders going on to complicate the picture. So that's a huge number. And does that answer the question? So,
Yes.
it's personal level. It's also when we are talking about or hearing about suicide, that should be the norm.
So I'll take up the question from the audience now.
I want to ask a question.
Yes, Kavita.
I want to ask, actually, I want to know that all the therapists and every doctor says, pick up your hobbies, go back to your hobby. I had reading as a hobby. I used to do embroidery. I used to binge watch these shows. But I had not only loss of interest, but loss of attention.
Yes.
So those two are constantly there, and I am always told, pick up your hobby, go back to reading. I can't read beyond a page,
Right. Right.
and I keep going back to the same line. It doesn't register.
Right. Right.
Doesn't it just doesn't go into my, even the most interesting murder mysteries are just like, okay, fine, good. I mean, good that the murder happened. Now we'll find the murderer. Okay, he'll be found, and it's all in my head. I'm writing a novel, and I've written it in my head. I've even cast Deepika Padukone, by the way. It's all there. It's all preset. My cast is in place. My novel isn't. I've lost interest.
Yeah. So again, we cannot, we know at the back of our mind, engaging in some kind of self-care, engaging in some kind of things or hobbies, that is important. That is important for us to fight the depression. Sometimes we are not at that point that we can push it. Many times I tell my patients, I even write on prescriptions, say if you like to sing on active on Smooth, that's something I can relate to. So you like it or not, you might be going through whatever you're going through. Even if you can sing a song, I can write it on prescription, sing a song every day. So, medication or go out for a walk for 15 minutes every day,
That is.
like it or not. And again, do not wait for, that's kind of work in progress. Let me give you an example of, say, chronic migraine. People live with it, they live with it for rest of their lives. They know their attacks, they know how it starts, how it progresses, what they can do when it starts so that it's not spiraling down. So even if I'm seeing an aura or some bright lights in front of me,
Yeah, yeah.
I know it's happening.
Yeah.
Sometimes depression is chronic. So part of the treatment process is learning how to live with it in a more fruitful way. So I want to be productive in my life. I don't want to be slumped. I can prepare myself to take actions from my end, whether I like it or not. So I don't wait for the best treatment, best medications, best therapy to make a change at that point, and only then I will start doing and engaging things that I used to enjoy. And again, I tell sometimes don't chase the sameness. As we grow, maybe our interests have changed. It's good to keep exploring, keep learning other ways that other people are doing stuff. Give it a chance, give it a try. Who knows what feels a good fit for you?
I'll return to my embroidery.
Hmm?
So let's
I
take up
used to
the
embroider. Now it's a
let's take up the questions now from the audience. The first question is about how to overcome repeated suicidal thoughts. A pep talk to myself works only this far. Is there a more sustainable technique that I can practice or use?
That's an excellent question. Okay. So again, coming back to that migraine thing. Suicidal thoughts, 2/3 of people, they have suicidal thoughts. They don't act on it. So that means that inherently, innately, we have some resilience. We don't want to die. We do not want to die. It's just that the situation we are in, that's becoming difficult for us to handle. So when we are having repeated suicidal thoughts, it's just kind of having a game plan. It's accepting it's going to be there. It's not going to be vanish. It's not going to disappear from our life. So we just have to be prepared how to handle it when it strikes us. So that safety planning can be done by, say, talking to somebody or to a therapist or family member, that step by step we have identified what we are going to do when the first signs start showing up. When I start feeling that, say, my life is not worth it, I'm a burden on my family, nobody is going to be bothered if I kill myself, who is going to care about me? When those thoughts start, going by, say, my previous experience, I have, first of all, the patient needs to identify what is it, how the process starts. What thoughts start in my mind that kind of leads me towards that direction that I'm thinking too much about death and dying. So write it out. What are my warning signs? So that I identify it. Now I identify warning signs. The second thing I identify is why do I live? And that's mostly to be done when I am in a more sane state, when on my happy days. What's the purpose? What's the meaning I see in my life? Write it at the top. Second, you write what are the cues? What is it that kind of that should shake me up? That okay, come back in the moment. Let's do all these steps one by one, so we are not reaching to that suicidal point. So that sometimes there can be self-soothing. Number 3, write down the self-soothing techniques that works for you. So maybe I may be stuck in that hopelessness or feeling that this is going to be permanent, there is no way out for me. Maybe some things work for me. Maybe it's the sewing or embroidery or listening to music or going out singing a sad song. Sometimes we can relate to it, but then the music has that healing power that it can come out, make us come out of whatever we were obsessively dwelling on. So it's a distraction. It's good to know the friends that we can contact. We can contact, even if we don't want to talk to them about suicidal thoughts or how serious our depression is. Just knowing that this is a friend I can call from my, say, med school or my colleague. And every time I talk to them, they make me feel good. They make me, or they remind me good things that we have shared together. They hold me back to life. And sometimes I tell my patients that even that, the speed dial mode, have 1, 2, 3. These are the people I'm going to contact one by one if I am stuck in that. And this is not a planning that can happen when somebody is in a suicidal state, because suicidality goes hand in hand with impulsivity. When we are stuck in that moment, we are likely to act on our impulse and carry it out. But as long as sometimes, I tell my patients, I work on a safety plan with them, stick it in your wall, any corner of your house, so that if you're in those thoughts, you need those reminders that do these steps one by one. That human connection is so important. And even if, like, Dr. Sanjay, we had that post on the group where you said you can count, if you need one person to reach out to when you're feeling suicidal, count me in. And that was so powerful. I thought that was so profound. Everybody needs to know that one person in their life that they can call, and they know for sure this person is not going to judge them, kind of call them cowardly, or kind of make them feel that they're weak in any way. This person, even if they cannot fix the problem, they are going to be a listener and kind of give that helping hand. That is so important. So that's the way to have a safety plan to deal with your chronic thoughts. And again, having an acceptance that despite doing things in an order, sometimes it's beyond you, but you still have to carry on. You may need to check in with your therapist or your psychiatrist. It's an emergency. Sometimes you may have to go to a hospital to be on an inpatient facility, which is kind of going to reboot your system. First of all, it's going to monitor you 24/7 so that you are not acting on an impulse. Second of all, you may need to change your medications, or you need that intensive support at that place. So again, realizing where you are and planning it accordingly, that's the way to deal with chronic suicidal thoughts.
The next question is very interesting. I think you already addressed in your talk before this. How can one nip one's depression in bud, especially when one knows that they're slipping into depressive bout because they recognize their own triggers as well as their responses to the triggers? How can one detach oneself from circumstances and situations in life so that one does not fall into the trap of extreme, low, or finally hopeless, helpless, maybe even suicidal?
So again, like we talked about this, knowing your triggers, that's an important sign. And knowing your triggers is also knowing how you had an experience with the same triggers in the past. So being aware, that's the most important thing. If it's in the early stages, nipping it in bud, we can keep doing the things that we know are helpful. Nutrition, sleep, exercising some form, engaging in something that is more productive, gives us a sense of, useful, productive use of our time. Reaching out to our friends. You mentioned something like even just going for a walk or having coffee together, not having, very in-depth, heart-to-heart conversation, just spending that time having that human connection, knowing somebody is there for us and we can rely on them. That can help nip it in bud. But again, once we know our triggers, if we can avoid it, why not? Say, for example, I had a friend who recently told me that he is constantly watching the news on TV, how many people are dying, the death count, how it is increasing. So not everybody is in that place where you can just see it in a detached way and you won't let it affect you. So if you know this is your trigger, what's the point? You don't have to engage in every single thing. So if the avoidance is possible, if there are some toxic relationships, toxic friends, and who are kind of just when you're with them, there is that negative vibe to it. If you know that, then back off. You don't have to engage in every single conversation. Knowing your triggers, avoiding it, doing some kind of housekeeping things that we talked about, which can avoid it from going further. But if it's going further, accept it. This is not something to be ashamed of. This is something, it's like a medical illness. It's just that, there is so much stigma that we don't talk about mental health in the same way as we do for medical illnesses. But accepting yourself for where you are and then asking for the right treatment. That's the way to go.
We are, I think, already running over time, but there's one last question, which is an important one. I'll take it up, and then maybe if there's any question from Anupma's live question, you can take that up as well before we wind up the thing. It's a very interesting, very important subject. So let us, I think, do a little extra time on this. The question is, I am 32 and newly married. My husband is very caring and loving, but there are days when I wake up with extreme sorrow and sadness and cry the whole day without any reason. I had tried to kill myself at the age of 19. After 3-4 years of medication, I was okay, but now I feel hollow, empty, very sad. Why?
We can't say why. Sometimes that's the challenge of depression. Sometimes it can happen when everything is going right in your life. I can't pinpoint why, but acceptance of that feeling that it's there and what to do about it. We talked about maybe this person needs to, start seeing a therapist or start talking. Well, if it really depends on how much of it is consuming this person's life. Is it something that's becoming day-to-day struggle? She had an episode when she was 19. She got medications. Her risk for developing an episode of depression, it raises anytime you have had some episode in the past. In fact, with every subsequent episodes, like say if I have had 3 bouts of clinical depression in my life, my risk is much higher than what it was when I had the first bout. So the risk is there. You may not be able to pinpoint why it is there, and that's the whole challenge. Sometimes it may be there when everything seems to be going right. So based on how much of it is impairment it is causing, maybe checking in with a therapist, trying to see what kind of therapy you may be interested in. That could be a good start.
I'll take one more question, which is a very interesting one also. When I was recommended medication, I was super resistant to it. It took me almost 12 hours to find a psychiatrist who was willing to start me on therapy and to have 0 to minimal medication. However, I was also drinking a lot back then. What is your take on managing a situation where someone is dealing with both depression and addiction issues?
Yeah, that can make things complex.
12 years, I wrongly read it as hours.
12
years it took to find a psychiatrist.
Wow, yeah. That's the irony. It's so prevalent in society. There is at least 1 in every 5 people, they have had clinical depression at some point in their life. But resources may be limited, there may be stigma attached to it, there may be kind of shame in asking for help. That may take so many years. You may get started with treatment, but you're not clicking with that person. So that's an average time length where you have wasted like 10 years of your life trying to get to that right state where you can. That's a very normal course. Sometimes people take that long to find the right help for themselves. Now again, substance abuse or any other comorbidities that may happen, that just makes the situations more complex. In fact, we cannot diagnose somebody with clinical depression if they are actively using any drugs or alcohol. There we may have to look into substance-induced mood disorders. So alcohol, other drugs, say opioids, pain medications, cannabis, benzodiazepines. These are commonly prescribed, used medications. People may use to kind of, they may have this feeling that they are self-treating themselves, or that's helpful for them, that's helping them to deal with their stress. It may help them for, say, couple of minutes, couple of hours, but then there can be, the symptoms are back full swing. So we cannot diagnose clinical depression once we have a period of abstinence of about few months where we know that this is not substance induced. So sometimes it needs a combination of both these independent issues that we are talking about, where we may have to go through an acute detox process, detoxification, then a rehabilitation process, so that we can, first of all, take care of our drug addiction and then start working on, if the depression is still going on or anxiety is going on, then we start working on more core issues with a more streamlined, focused direction.
Great. So, Anupma, do we have any question live from the audience?
Yes, Dr. Dhawan, we have one question that hasn't been covered so far.
Yeah.
So this question says, often one feels better with continuous medication and therapy, and then people tend to feel confident and they quit medication or therapy suddenly because they've just started feeling better when they start feeling confident. So how to know when to continue and when the therapy has served its purpose?
Wow. So again, that comes back to a patient being empowered and psychoeducated about what to expect from medications or how long do you need to commit to medications. If it's say, it depends on if we are talking about your first clinical depression, first episode, or is it your fifth clinical depression, or fifth clinical episode of depression. So how long to continue it depends on where we are. If say I see somebody who has never had bout of clinical depression before, and this is the first time they are coming with such serious symptoms, my recommendation is the treatment would take at least, it needs to continue for 6 months. So there we are talking about treating the symptoms acutely, we start getting better, and then there is a maintenance phase. And after we have plateaued it, we slowly start weaning it off after a period of 6 months. And I educate my patients that you may not want to take it. You may start feeling, why am I taking it when even I'm getting better? But once you stop the medications, there is a risk of rebound. So at least 6 months when we are talking about first clinical episode. Now, as the episodes have increased, sometimes say the third episode and the previous episodes have been associated with suicidality or needed inpatient admission. So there sometimes the treatment needs to be done up to 2 years. That takes, that's a time consuming process that takes some commitment on part of the patient to kind of accept it that this is what it is. Now, sometimes based on patient preferences or how well they are doing in therapy, we take a chance. I've had some high functioning patients who absolutely, they were part of the process, part of the journey. They were compliant with medications, they trusted my recommendations, and then they said, okay, so Dr. Manpreet, we have been taking it, we have been working on it for 1 year. I know you told me 2 years minimum, but I'm doing so well. I have learned all the coping skills in the psychotherapy. Can we try it out? And they're based on, I'm not a dictator that I can force medications on somebody. This has to be a mutual process. And if that process is lacking in your relationship with your psychiatrist or your therapist, it's not going to work. So part of empowering them is once you have educated them, once they know the risks involved when you are taking the medication off prematurely and they're okay with it, then work with them. You can take them off as long as they're prepared for it. So does that answer?
Yes,
so the timeline is different. How long do we need to continue? There is no one size fits all. It really depends on custom tailored to your needs. And it also depends on when we're going through this journey together, respecting where the other person is coming from. And if it's taking a chance together, we do it as long as we are prepared. I see a lot of adolescent teenagers who have been in treatment for, say, 2 years or so. They have done well. They want to be off medications now. We also choose the time of the year when say, summertime or winter time, when the school is off. So if we are taking a risk of stopping it prematurely, we want to make sure that it's causing as minimal impairment as possible in their day-to-day life. Sometimes it works, and then they don't need to be on medications, and everybody's happy.
So that's a very good session so far, and it's time for us to bring it to close. Anupma, any more question you have?
No, Dr. Dhawan, we do not have any more questions.
So we're done with the question, we're done with the talk. So friends, let me just give some concluding remarks on the depression part. हमें खांसी होती है, we don't mind and we don't point fingers at somebody else. We have sneeze, we have sneezing, we have fever, headaches and all. We always say, fine, I'm having headache, I'm having fever, and we seek help, we seek medication. We don't mind. And we don't even point to somebody, why are you having fever? There's something wrong with you. No, we just say, we offer help. Okay, fine. Kerosene खा लो, doctor को दिखा दो, ये कर लो, वो कर लो. we should take mental health issues also in the same way, in the same stride. It is just another illness. In the milder form, we can take some home remedies, we can help ourselves, we can do our routine maintenance. But when it goes slightly beyond the mild form, we should seek expert help, which may be in the form of a psychiatrist or a psychologist, and mostly both of them. We should do, very importantly, we should do preventive maintenance. Like we take care of our computers, the software, the hardware, we do some preventive maintenance routine. We should do those routines on ourselves also. So sleep well, eat your meals on time, eat healthy diet, drink plenty of water, do exercise regularly, sun exposure, have some form of hobbies and entertainment, achieve work-life balance. These all things are preventive housekeeping work that you can do, which will, maybe prevent you of going from severe form, or at least will help you recognize that when the depression is going out of control and when you need to start seeking expert help. So Dr. Manpreet Khemka, thank you very much for being here with us on the chat and sharing your valuable knowledge with us. Kavita, thank you very much for sharing your experience and giving us this platform to talk about these issues. Anupma, thank you for your help. And guys, before we go off, I have an announcement to make for the next talk. And that is that next week on Friday at 7 p.m., we have another expert coming to us, Dr. Madhusudan Singh Solanki, who's a senior psychiatrist at Max Healthcare, New Delhi. And we'll be talking to him about anxiety and stress related to the COVID pandemic, which is there. So,
Dr. Dhawan, I'm sorry to interrupt. I see Dr. Nidhi raising her hand. I think she has.
So we have another question live. Please go ahead.
No, not a question, just a small input. I totally agree with whatever Manpreet was saying, but something that I wanted to tell Kavita, that sometimes when things are not in control and you don't want to do anything, pets help.
Pets, right.
Pets help.
Great. Fine. So, well, I have a talk planned for tomorrow where I'm talking about, I'm starting another chat series called the Live Chat. And I'll be covering up those issues also over there. If you guys are interested, you can, join in tomorrow and I can share the invitation for that. So, but next week, please do join us back on Friday at 7 p.m. Dr. Madhusudan Singh Solanki, who is a senior psychiatrist, will be talking about anxiety and stress related, especially to COVID. So thank you very much for being here. Thank you all. I am Dr. Sanjay Dhawan, your host, signing off.
Thank you.
Thank you.